Hi, I'm Han Brown, the host of the Boomer Living broadcast. As the baby boomer generation ages, they are increasingly focused on their health and well being. However, they face many challenges, including senior health care, dementia, Parkinson's, caregiving, technology adoption, affordable senior living options, and financial insecurity. These issues can be very difficult to navigate alone, which is why we created the Boomer Living broadcast. Our goal is to provide accurate and up to date information on all of these topics so that the baby boomers and their loved ones can make informed decisions about their future. We also offer a wide range of resources and support to help the baby boomers and their families through every stage of their journey. So, so whether you have parents or grandparents or just starting to think about retirement or already enjoying your golden years, we're here to help. So the aging process is different for everyone, and we can learn a lot from each other. And that's why I love to hear from you. If you have any questions or comments about your own aging journey, please don't hesitate to share them with us. By sharing your stories, we can help others to understand the aging process and feel more confident about the future. So, thank you so much for tuning in, and I hope that you'll find the conversation informative and helpful. So, today's topic is don't let Alzheimer's or Parkinson's steal your loved one's dignity. Alzheimer's and Parkinson's diseases are two of the world's most common neurological disorders. Alzheimer's affects approximately 6.2 million people, while Parkinson's affects nearly 10 million, according to the World Health Organization. These diseases can have far reaching consequences for both patients and their families. Alzheimer's and Parkinson's disease can cause depression and anxiety, in addition to memory loss, confusion, and mobility issues. These diseases have tremendous impact on healthcare systems and families, leading to increased burdens on care providers and significantly altering the lives of those affected. There is no cure for either disease, but there are treatments that can help with symptoms. Medical marijuana is a promising area of study for both Alzheimer's and Parkinson's disease. While more research is needed, preliminary evidence suggests that cannabinoid may aid in the improvement of sleep and reduction of inflammation and the protection of nerve cells from damage. Another promising area of research is personalized medicine. This method entails tailoring treatment to the individual patient, taking into account factors such as genetic makeup and lifestyle. We may one day be able to develop more effective treatments and even find a cure if we better understand the causes of these diseases. But until then, we must continue to support patients and their families as they face the challenges of Alzheimer's and Parkinson's disease. So today, my guest is Dr. Flavio Costa. He is a neurologist and a movement disorder specialist. He's a professor of neurology at the Rio de Janeiro Federal University and director of movement disorders at the Clementino Frege Filho University Hospital. He has dedicated his life to teaching and researching the causes and potential treatments of of neurodegenerative diseases such as Parkinson's, Huntington's, dystonia, and non-modal symptoms of Parkinson's disease. So, Dr. Flavio, welcome to the show.
Well, thanks for having me, Han. It's a pleasure to be here with you.
Thank you. Thank you so much. I appreciate the work that you do and appreciate the opportunity that we have to bring awareness on this horrible disease. So, thank you so much.
Thank you.
Yeah. So, please tell us a little bit about yourself, both personally and professionally.
Okay. I'm 45 years old. As you mentioned, I'm professor of neurology at the Federal University of Rio de Janeiro. I became professor at the age of 38. And before this, I was professor in a private university here in Rio de Janeiro, Estácio de Sá University. I have training in neurology in Rio de Janeiro, and I also had a fellowship on movement disorders with Professor Andrew Lees. So he's one of my mentors in movement disorders. So I dedicate my life, probably the last 10 to 15 years, studying non-motor symptoms in Parkinson's disease. My master's degree was developing in studying quality of life in patients with Parkinson's. So we did a study with more than 200 patients in Clementino Fraga Filho Hospital, and we got to the conclusion that non-motor symptoms are very, very important symptoms for patients with Parkinson's, and depression is the main factor for loss of quality of life. And then in my PhD, I study impulsivity in patients with Parkinson's disease. We had a model of cognitive assessment of what we call drug-naive patients with Parkinson's, and we published a very nice study showing that patients with Parkinson's, they have underlying impulsivity even before the treatment with levodopa or dopamine agonists, which are the main drugs. So we have shown that patients with Parkinson's, they have impulsivity even in very early stage. So and this impulsivity can be increased by, especially by the dopamine agonists. So it's just like some pieces of information that we have studied. So it's a long road, and I'm very happy and proud to be here with you, Pam.
Oh, thank you. Thank you so much. I'm honored.
Nice to
So,
meet you.
the global prevalence of Alzheimer's and Parkinson's disease is very alarming, with millions of people suffering from these debilitating neurological conditions and putting a strain on the healthcare resources and families' lives. So, let's start out with what's the difference between Alzheimer's disease and Parkinson's disease?
Yes. Well, both diseases are considered neurodegenerative disease. But Parkinson's disease, is the main feature is the motor symptoms. So it was described by James Parkinson in 1917. He described 6 patients with slowness of movement, a symptom that we call bradykinesia. And patients with Parkinson's, they also experience other symptoms that we call non-motor symptoms, like depression, apathy, insomnia, and the cognitive decline of Parkinson's disease generally occurs in the late stages of the disease. And the first flag is the hallucinations that the patient can experience. So hallucinations and falls are hallmarks of cognitive decline and progression of the disease. Alzheimer's disease, it's basically a disease that affects the cognition. So the main feature is memory loss, but patients with Alzheimer's disease, they can develop other symptoms like apraxia, aphasia, which are problems with speaking and language and motor skills too. And patients with Alzheimer's, they can develop behavioral problems and sleep problems. What both diseases have in common, is that we know today that both diseases, they have what we call preclinical or prodromal phase. So at the moment of the diagnosis of both diseases, we know that the pathology of these conditions are present for at least 10 to 15 years, which is a very challenging issue. So we are doing the diagnosis in conditions that starts very, very like 10, 15 years before. So that's the main challenge when we make those diagnoses. In terms of pathology, both diseases are completely different. So Alzheimer's disease is considered what we call tauopathy, which is the main dysfunction is what we call tau protein. The tau protein is a protein that it's very important for giving the architecture of the neuron, and also other markers, the beta protein accumulation in this disease. And Parkinson's disease is a condition that the main feature is the accumulation of what we call alpha-synuclein. So it's in the group of synucleinopathies, which also is shared with other conditions like MSA, multiple system atrophy, and also Lewy body disease. So in terms of pathology, are completely different conditions.
Mm-hmm. I'll tell you, I painfully living my own life, seeing loved ones with dementia and Parkinson's. And I think that's one of the reasons why I'm very passionate to have folks like
Yes,
yourself to bring awareness, educate, and inform people that, like it or not, it's part of life. And the sooner
yes,
that you get educated, informed, and perhaps even take ownership of your health, because I think our conversation should influence people, I hope, to how they live their lives and choices that they make day to day. So thank
yes,
you.
exactly. Thank
Thank you.
you too.
So now, how do you think healthcare will be impacted by these diseases in the future?
Yes, it's already impacting. You know, these diseases are very prevalent and very incident. So we have a lot of new cases, and the main risk factor is the aging process. So my view and my perception is that countries with low income populations and great amount of population will be the most impacted. So we're talking about Asia and Latin America, and specifically Brazil. So it's a huge challenge because as the population is getting old and the health care system and all the resources we know that are limited, so it's a main issue, it's a main problem. So in the United States too, I think it's a huge problem because
Mhm.
United States it doesn't have a universal coverage system, so it's like basically like an insurance system,
Mhm.
and the costs are skyrocketing in the United States. So I think uh, countries and nations with universal healthcare system will do better than countries with healthcare insurance. You know, because the access is more open,
Mhm.
and generally we have a base at the base of the system, what we call GPs, general practitioners, that can do the first and they can follow up patients. And if we work in the correct way, so giving education and giving tools for GPs to at least think about this disease, and they can follow up better those patients. So in nations with insurance, I think the care is more fragmented and
Mhm.
patients don't have the same quality of, they might have some quality of access in research institutions and in clinical trials. But I think the daily basis is even harder than when you work in a country with a universal coverage healthcare system. That's my perception.
Sure, sure. I think the last time I saw, at least in the US, to care for someone with dementia in his lifetime is a little less than 400,000.
Yes, yes,
It's tragic.
yes,
Yeah.
yes.
So
And
now,
in Brazil, we have a universal care, healthcare system. It's like a hybrid system. But my perception is that patients have better access when you have a universal care, healthcare system. The same thing I saw in UK with the NHS. I think patients do better in this type of system, specifically when you have a general practitioner taking care of those patients.
yeah, absolutely. I know for us in the US, we're going through a renovation of the healthcare system to get ready for such diseases like this. So
Yes.
thank you. Now, what can we do to support those affected by Alzheimer's and Parkinson's? What's your take?
Yes, I think everything starts with good and accurate diagnosis. You know, I feel very sad when I make a diagnosis of dementia in late stage without a doctor not even thinking about it. You know, sometimes families they think that it's normal to get like a little bit more forgetfulness after 80s, but you know, those are early signs. So I think the accurate and early diagnosis is very important. But when I'm talking about diagnosis, and I'm not talking about an app diagnosis or a co-doctor in front of you saying that, oh, you have Parkinson's or you have Alzheimer's, and that's it. No, I'm talking about clinical skills. I think we need to educate healthcare providers to provide the diagnosis and share a plan for patients and families. We can never forget about the families, because when you give a diagnosis of a dementia, for instance, it affects the whole environment of the patient, so it affects the family life. So it's very important to share a plan. And when we think about Alzheimer's, for example, we have to think about this plan, and this plan involves in the central of the treatment a caregiver. And caregiver might be someone from the family, might be some professional, or might be in a hospice, for instance. But all of these plans must be shared. So I think it is crucial to have a caregiver as your partner, you as a doctor and the family. So when you have both caregivers and doctors working together to find solutions, I think the treatment is much, much better, and you can pass through the crisis in the better way. So you're going to have some turbulence when you give a diagnosis of dementia. So the most important thing is to be prepared for this and share the plan with families. That's my view.
Yeah, I echo that. I tell you, when it comes to Parkinson's and dementia, it's one of these things that it's not within the vertical of neurology. We're talking, like you say, caregiver, social work. I mean, there's multiple key stakeholders into this
Yes, exactly.
providing care to the loved ones. So, I mean, at a healthcare medical level, it's all those key players intertwined and working together, right? And not just
Yes.
depending on your primary care or your neurologist and so forth. And I learned the hard way on a personal level. Again, I can't make a statement strong enough is that we need to normalize these kind of conversations and educate people, because sooner or later, maybe sooner than what they want, you're going to be hit with something. So that's what
Yes.
I would advise folks to get educated. Now,
Yes.
right now, go ahead. Go ahead.
So I was while you were saying that, I'm thinking. So we're talking about a condition, for example, Parkinson's affects 1% of the population over 65-year-old, and dementia, it's around 30% of the population are around 80 years old. So it's very common. So this is something that we must educate people. And as we don't have a cure, but we have tools to make it more comfortable and more effective for families and patients. So that's the point.
You mentioned we don't have a cure, but do you think that we'll ever find a cure? And what do you think it'll take to find a cure? It's a loaded question, but I'm
Yes, I
curious
think,
about your take.
yes. But, I have a clear view about this. I think we're going to have a cure for those diseases, but it's going to take time. It's not a matter of money or power, and I can assure you. We have two former presidents of the United States that Ronald Reagan had Alzheimer's disease. George W. Bush had Parkinsonism. And we had a former Prime Minister of UK, Margaret Thatcher. She died with Alzheimer's. It's not about money or about researches only. I think it's about following the right path for this. And in my view, we're gonna move to a more personalized approach in the next coming years. What do I mean by personalized approach? So we're going to collect many informations from patients that we know that can change the course of the disease, like clinical markers, biomarkers. We're going to study what we call pharmacogenomics to understand what symptomatic drugs fits better for those patients. And probably we're going to develop what we call modifying drugs based on genetics. So when we talk about Parkinson's, for example, we know that there are many gene factors, many gene mutations that can predispose or can cause Parkinson's, like Parkin, GBA, many genes. So I think we're going to start by these genetics modifications. I'll give you an example. We have some studies with what we call GBA mutation in patients with Parkinson's. It's a mutation. It's a mutation that also causes a disease called Gaucher disease. And probably we're going to start giving the making the solution for this specific mutation. Just giving you an example. And then we can move forward to other solutions. So I'm very optimistic about what we call protein infusions in the future. I think this might be a very interesting solution for patients. But I think it will be like what we call multimodal approach. You know, we're going to have to understand each individual, each clinical feature of the individuals to make it personal. That's my view.
Thank you. Now, what can we do, or are there ways to reduce the risk of Alzheimer's and Parkinson's disease?
Yes. My view about this disease, you know, as I mentioned, so we have a very complex interaction between environment, genetics, and clinical features. So not these patients are when you see like 100 200 patients with Parkinson's, you see very clear that there is no each in the Parkinson's patient which is equal to others. So we have like clinical profiles, clinical what we call clinical phenotypes, and we can work with understand these clinical phenotypes. You know, my perception is that understanding clinical phenotypes, we can move forward. So I'll give you an example. We already have pretty good data showing that patients with Parkinson's disease that are young and tremulous, they have better prognosis than patients with Parkinson's disease that are old and have balance problems. So it's the same disease in terms of pathology, but two different clinical phenotypes. So that's my view about those diseases. So we need to understand better the clinical phenotypes and the genetic interactions, so we can treat these patients in a very personalized way. That's my view about this.
Thank you. So neither disease has a cure, and treatments can only alleviate the symptoms. So as a result, patients can lose cognitive and physical function. And both diseases are very costly to treat, and many patients frequently require long-term care. So as our population ages, the number of people living with Alzheimer's and Parkinson's is going to rise. So this means that effective therapies and diagnostic tools will be needed urgently. So
Yes.
what do you think is the biggest challenge in developing therapies in Alzheimer's and Parkinson's?
Yes, I think the challenge is that when you do like a clinical development program, you are only focusing in that drug. So I will give you a clear example about this. In the last 20 years, what's the theory about Parkinson's disease and Alzheimer's physiopathology? Is that those proteins were toxic to brain. So what we developed antibodies that were meant to clear the brain from those proteins. And we spent a lot of money, so much resources, based on a false theory, because all of these drugs, they failed. So we could achieve to reduce the protein, but we had no clinical relevant endpoint. So I think the challenge, and is to make the right questions and make the right assumptions of what we are researching, and also to make the right connections with other therapies that we have. So in pharmaceutical industry, I think one of the limitations is that when you do a clinical development program, it doesn't talk with other things that are doing. So you just study like the primary outcome and secondary outcomes. This is not enough, you know. What we have to do, what we need to do, we need to build bridges from these clinical development programs and try to connect this with other solutions. And this cannot rely only in the industry. You know, we must involve the what we call neutral parts, like the university, which should be neutral in doing research, and also other players like government, like agencies, like specialist panels to find the solution. So that's my view. So that's why we didn't reach yet like a good outcome in terms of research, because I don't think we have a effective conversation between these players. You know, it's the system deficiency, in my view.
Mm-hmm. Mm-hmm.
I don't know if you agree with this view.
Well,
What's
you
your
know
take on
how I
this?
how I see it is, you know, everybody, like the key stakeholders that you mentioned, I think they all have to go in with an open mind and with a common objective. Too often, our views might be biased because we come in with some motives, some ulterior motives.
Mm-hmm.
I'm just putting it out there, right? I think if principally, if everybody's aiming to have the same objective, and I think collaboration, I it's very useful. So.
Yes,
Um,
yes. I think it's all about collaboration. You know, you don't do big things in life alone. And I think the industry also needs to understand this. I think that the collaboration with the universities, and I think it's key. It's a key part of this. You know.
And having money or power, does not necessarily mean that your views are, you know, more right
Correct.
or not. Yeah,
Yes. Yes. Exactly.
yeah. Okay, so let's talk about some research. What kind of research are being done to find new therapies for Alzheimer's and Parkinson's? Let's talk about that.
Yes. As I've mentioned, unfortunately, the monoclonal antibodies, most of the studies they fail. So we are, I think, in a transition point now. So we look back and we see that we ask the wrong questions. So all of these clinical development programs, in my view, that's my personal view. I'm pretty much sure that it can't be shared with other key opinion leaders on the field. But in my view, the monoclonal antibodies is not the way to go from now. I'm very excited about the studies about in what we call protein replacement therapy. You know, we have already good preclinical data showing that as the brain degenerates, the proteins and that proteins that aggregates like beta amyloid and synuclein, they are what we call end products of a molecular dysfunction. And this molecular dysfunction can have many, many reasons. Can be like a mitochondrial dysfunction, can be like what we call lysosomal dysfunction. And there's many hypotheses and a nice paper that has been recently published that some environmental virus like HSV1 can start this process in some patients. So it's a very complex interactions of molecular level and environmental problems, as I've mentioned. But what we have, we know that these proteins are, as the disease progresses, these proteins go low. So they are starting to fall, they start to accumulate. And the idea is to provide patients with what we call soluble proteins. And we know that maybe if we at least restore these proteins on patient's brain, it might stabilize the disease. But it's probably this is just part of the solution. It's not the whole solution. We also can study what we call inflammation profile, and like coenzyme Q10 and other inflammation markers, and try to find solution to restore and to use anti-inflammatory products to restore what we call neuroinflammation. And what also has been it's also something very interesting. It's what we call omics, metabolomics, proteomics, transcriptomics, and microbiomics. So it's the body profile about the proteins and also your DNA and the interactions with the DNA, for example, with what we call microbiomes. And this is very interesting too, because one of the things that have been studied in the last 10, 15 years is what we call gut-brain connection. We know that our gut, our intestine, is connected to the brain, and maybe chronic inflammation, it's what triggers the neurodegeneration. So studying microbiome, it's something that I think it's very promising in this field. So as I mentioned, it's like what we call multimodal approach that includes genetic analysis, protein replacement therapy, microbiome analysis, and also using clinical biomarkers to guide the prognosis for those patients. And also, I'd like to mention what we call pharmacogenomics, is that to study the metabolism profile and the tolerability profile of each of the drugs that we already have available, to try to offer the safest and the most effective treatment for patients. So I think that's the way to go.
Do you think there's any one of those that have most promise?
I'm very excited about protein replacement therapy. And I'm also very excited about studying the role of endocannabinoid system on that, because we know that the endocannabinoid system, it's a system that we have, like the respiratory system, like we have cannabinoid receptors in the brain. We have endocannabinoids that modulate many functions, and we know that to summarize that, the endocannabinoid system is what we call the homeostatic system of our organisms. So I think I'm very much interested in studying the impact of the modulation of the endocannabinoid system in disease progressions like Parkinson's and Alzheimer's.
That's great. So what do you think are some of the most unmet needs that Alzheimer's and Parkinson's patients' families have?
Yes, a lot of unmet needs. You probably can share with us, but my perception as a doctor, the first unmet need is the fear of the diagnosis, the uncertainty about the diagnosis. So when you give a diagnosis of patients for a patient, imagine I see a patient with 45 years old with early onset Parkinson's disease, and works as an engineer and has 2 kids and a family. So I think the fear about the diagnosis, the fear about the future, it's one of the things that we have to deal with families. And what's the best way to deal with this? It's a good doctor-patient relationship. Not only doctor-patient relationship, but also make sure that this patient will have access for what he needs or she needs. I think dealing with the diagnosis is the most challenging at the beginning. And after this, I think what we call behavioral symptoms, it's a very problematic issue. So when patients have psychosis, like pathological jealousy, or some patients with what we call reckless generosity, and dealing with these behavioral issues is very problematic. And also the sleep disturbances in patients with dementia. So when patients don't sleep well, it causes a lot of disruption in the family environment. And other aspects is to have access to the healthcare system. I think it's a barrier. It's fragmented in many places. So patients that don't have what we call a smooth journey in the system. So they might have an access to a neurologist once in a while, or might have access to speech therapists or physical therapy. So I think to to give the access of what patients needs, which is a multidisciplinary team, it's one of the most challenges for those patients and families, and also the costs of this. So that's another point
Yeah.
that it's a problematic issue.
And I hope that anyone is listening now or months or years to come don't feel like they have to hide,
Yes,
embarrassed, ashamed, right? I think those are very natural feelings that the patient, the families, and caregivers may have, but there's no need for that. We need to
absolutely.
normalize those kind of conversations because too often, myself included, my family haven't gone through the journey. Too often in the beginning we're in denial, not understanding what it is, and you want to hide. It's not something you put it out there to your neighbors, people at church or school.
Yes,
So
exactly. But
yeah.
I think that, as you mentioned, the way to deal with this is have an honest conversation and never hide. So it will not bring the solution.
All right, but let's hone into the role of cannabis, medical cannabis, what it plays in the Parkinson's disease and dementia. So, I guess, do you think that medical cannabis can help to delay the onset of Parkinson's disease and dementia? And
Yes,
why?
yes. This is a very good question, and we already have some good preclinical data on that. We don't have any clinical data showing that medical marijuana or cannabinoids can change the course of Alzheimer's or Parkinson's disease. But we have some preclinical models that indicate that these molecules, the substance, can impact in what we call neuroinflammation. We know that THC can promote what we call neurogenesis in animal models. And we also know that these phytocannabinoids, they can influence the deposition of proteins. So if you have less deposition of proteins in the brain, it means that probably you are acting in some molecular level. So I think we already have enough data to show that we should, and we must put this substance on clinical trials. You know, but what's the main barrier about this substance? First is what we call pre-treatment of people. They confound what we call recreational use of cannabis with medical, completely different areas. So we must do a split in this thinking. And also, one of the problems is that, and one of the challenges is that these substances, they don't have patents. So in the system that we live, most of the players are looking for a patent. So as natural substance, you cannot patent it. So we don't have enough research to put too much money to do like a cohort study, a long-term study to understand the impact of those substances on the clinical development or the clinical evolution of those diseases. I would love to be able to do this. My view is that we should start in patients what we call high risk of transition to Parkinson's. For instance, patients with a symptom that we call RBD, Random Sleep Behavior Disorder, that we know there's preclinical symptoms of patients with Parkinson's. And we know that patients after 65 years that have RBD, they are like 75% risk of converting to Parkinson's or synucleinopathy after 5 years. So those patients might be good targets to study cannabinoids to see if it can influence the development or the transition to the clinical picture of the disease. But we also know, Han, that this substance, they have some interesting symptomatic effects on patients. So we already have small clinical trials. The Michael J. Fox Foundation just released a nice paper, and in one prestigious paper, Parkinsonism-related disorders, with 1,800 patients with Parkinson's disease, showing that this substance or these formulations can bring relief in terms of insomnia, pain, anxiety to those patients. And some patients with other formulations with small or medium dose THC dose, they can have some relief in terms of rigidity and tremor. So I think it's a very interesting paper, and I invite all our viewers to go to this paper and take a look. And I think it's the first. It's an open path for clinical development. I'm very excited about cannabinoids in patients with Parkinson's and Alzheimer's.
So, what would you say to someone considering to use medical cannabis to treat Parkinson's and dementia? What would your advice be to them?
I think my first advice is to share with the doctor this idea. In this paper from Michael J. Fox Foundation, they 30% of the patients didn't mention that they were using cannabinoids to their doctors. Can you imagine this? 30% of the patients were using the formulations and didn't share this with doctors. So
why do you think that is?
I think it's because they are probably ashamed of that, and they don't want to share and be criticized by the doctors. So I think this is clear for me that for those patients there is a clear rupture in the medical-patient relationship. Because if I go to a doctor, I would like to tell and share the plans with doctors.
Yeah.
So if 30% of patients don't share this with doctors because they are afraid of being criticized or by the doctors, you know what I'm saying? So yeah. I think the first thing is to share with doctors the idea, and what we have to keep in mind, we don't have enough evidence to support that the cannabinoids we're gonna cure Parkinson's or Alzheimer's. But I think we have a right information that it can help in sleep, pain, and anxiety. And we already have enough information showing that we can reduce neuroleptics and we can reduce benzodiazepines. So I think if patients have these symptoms, and this symptoms is a problem, then I think they should talk to doctors about this. The challenge in the United States, so I can give you my take on this, is that cannabinoids in the United States are not prescription drugs. So doctors don't prescribe it. They can only advise. So my view is that it's urgent to have a change on this in the United States. I think the liberalization and should include cannabinoids as prescription medicines to patients. Brazil did this 2 years ago. So in Brazil, cannabinoids are prescription drugs. So you don't buy it at 7-Eleven, or you go to your doctor and you share this plan with doctors. And my view is that it has changed the way the doctors view cannabinoids, because when you transform formulations into prescription formulations for patients, you give value to this. So you're gonna have the prescription under doctors' surveillance. And what I see in Brazil is a revolution in terms of care for patients with Parkinson's, not only with Parkinson's, but also in children with autism and epilepsy. So if I can give you an advice, I think United States should move fast for a prescription to allow doctors to prescribe cannabinoids. And obviously, you have to set up minimum standards in terms of quality, concentrations, and limits of THC. But I think it's a way to go.
Great. Thank you. Thank you so much. Now, I know we touched a bit on personalized medicine. I think it just deserves a whole conversation itself. Is there anything else that you would like to add to personalized medicine, that perhaps that's the best way, or one of the best ways to go?
Yes, I think the endocannabinoid system should be included. The evaluation of endocannabinoid system probably in the future will be used as one of the tools. We have what we call endocannabinoids. The main endocannabinoids, it's called anandamide. I'm not sure if you heard about this name, but I'm going to tell you a brief history about anandamide. It was described by Professor Rafael Meshulam's group in Israel in early 90s. It's what we call ethanolamide. It's a kind of lipid that interacts with the cannabinoids. And they didn't know how to name it because they didn't know how to name it. So they choose the name Ananda, which in Sanskrit means happiness. So anandamide, which is the main endocannabinoid, is some of, in my view, might be one of the targets. So we already know that when we have neurodegeneration, the levels of anandamide go up because it's like a feedback. So you have to adjust your levels of cannabinoids to adjust the dysfunction. So probably anandamide will be included in some neurodegenerations as part of the panel of anti-inflammatories, and with my use endocannabinoids as a tool marker for personalized medicine and follow-up of those patients.
Mm-hmm. Wow, Dr. Flavio, I thank you so much for your time and expertise and your wisdom and your dedication in this field. In closing, do you have anything else that you would like to add?
I would like to thank you so much for the invitation and say that it's an honor for me to be here. So the first time we've met, I told you, look, I work in Brazil, I do research in Brazil, and I remember the first thing you said, look, this is a world problem. So it's a worldwide problem. So to have the solution, we must include everybody, not only people in the United States, but people from around the world. So your invitation make me feel part of this. So thank you so much for inviting me.
Wow. Well, thank you so much. Thank you so much. I'm honored to have you be here and be in this conversation. So, I guess in closing, I clearly Alzheimer's and Parkinson's diseases are serious global issues. While there is still much to learn about Alzheimer's and Parkinson's diseases, new technologies and treatments are likely to improve the diagnosis and treatment in the years to come. So, in the meantime, it's critical that patients' families stay informed about new research so that they can make informed care decisions. So, next week, the topic will be nutritional tips for brain health, longevity, and healthy aging. Well, it's no secret that what we eat has a significant impact on our overall health, but many people don't realize that what they eat can also have major impact on their brain health. The truth is, your brain is the most important organ in your body, and you need to do everything you can to keep it healthy. Our diet can have a significant impact on our mental and physical health, affecting everything from mood and energy levels to our susceptibility to Alzheimer's and dementia. So tune in next week. So we hope that you enjoy this conversation, and please make sure to subscribe to our Boomer Living broadcast, iTunes, Spotify, Google Play, and so forth, and also subscribe to our YouTube channel, Aging Media Show. And thank you so much, and have a great day.